Today's topic is relevant to each and every one of us because while it's obvious that sleep is an essential part of life, since we spend a third of our lives doing it, it's become very clear that sleep is an essential part of our systemic and cognitive health. It's now very clear that certain sleep disorders significantly increase the risk of stroke, cardiovascular disease, MI, atrial fibrillation, dementia, just to name a few. And despite the enormous evidence base that has led to this clear understanding of the relationship between sleep health and systemic health, sleep continues to be massively under-assessed and undervalued as an essential element of the clinical evaluation of every patient. And not surprisingly, therefore, sleep disorders are grossly under-recognized and undertreated. Insomnia alone occurs in at least 20% of the population, and only 1 in 10 seek medical attention for it. And while the prevalence of obstructive sleep apnea, for example, varies according to its severity, it may affect up to 1 in 3 people, and this prevalence increases significantly with advancing age. Unfortunately, and as Dr. Watson, our guest speaker, has highlighted in some of his publications, at least 80 to 85% of people with obstructive sleep apnea are not diagnosed or treated. So it's a major public health problem. On top of that, we're developing a brain health center here, and there are also certain sleep disorders that identify people who are destined to develop neurodegenerative diseases, giving us as clinicians a window of opportunity to intervene. So for the scope of the problem, one needs to look no further than the fact that the sleep aid market in 2019, prior to the pandemic, was about $80 billion. So it's a big problem, and a lot of people are taking a serious interest in it. One of the problems, of course, is that there's one board certified sleep medicine physician for every 45 to 50,000 Americans. And there are large pockets of the country with no sleep physicians at all. But that doesn't even address why sleep continues to be so under-evaluated in clinical practice, because it's not really addressed in specialty care or in primary care. So the question is how to tackle this massive public health problem at scale. And I think that is where consumer sleep technology comes in, as these technologies have seen explosive growth, substantial uptake in the population, as people are interested, and people will be asking us about these. And so they will undoubtedly, I think, play a major role in solving this dilemma of poor sleep health. So it's with that preamble now that I couldn't be more delighted to introduce our guest speaker today, Dr. Nate Watson. Dr. Watson is a professor of neurology at the University of Washington, where he also co-directs the Sleep Medicine Center. He's also the director of the Harborview Sleep Clinic. He is the past president of the American Academy of Sleep Medicine and past president of the American Board of Sleep Medicine. He is renowned for his research and development of state-of-the-art sleep technologies to unobtrusively measure sleep in patients' home environments. So Dr. Watson, thank you so much for being here with us today. We really appreciate your time on a Friday afternoon. We look forward to your presentation, which you've divided into 2 parts, which is great. So we'll have 2 question and answer sessions. And so welcome, the floor is yours.
Thank you so much for that kind introduction, Dr. Dodrick. And it's really my pleasure to be here today. And I want to thank the Atria Institute for this opportunity. And I think what I'm going to talk about today is going to be directly relevant to Atria, because I know that Atria, as you mentioned, is interested in improving public health and doing it in innovative ways, validating new pathways to health. And my talk today is going to be focused on looking to the future of what potentially sleep medicine will look like as we try to tackle these access problems that Dr. Dodrick so eloquently pointed out. These are my conflicts. I am on a consultant for SleepScore Labs. I'm involved with the patent behind the technology that I'll introduce to you a little bit later in my talk, and then also consult with Supermoon Capital, which is a venture capital firm focused on sleep health. So this is how the talk is going to unfold, or the whole morning actually, or afternoon, depending on where you are. We're going to cover some general concepts regarding consumer sleep technologies first, just to get a lay of the land essentially. Then I'm going to go through devices that claim to track or screen or even diagnose sleep disorders. Then we're going to go through and address some of the challenges that are out there related to these technologies. We're going to take a break. There's going to be an opportunity for people to ask questions about that portion of the talk. And then we're going to move on to talk about what have consumer sleep technologies taught us about human sleep up to this point in time. And then afterwards, again, we'll have another opportunity for people to ask questions. So this is what it looks like to get a sleep study or a polysomnogram in 2022. Some of you may have had a polysomnogram personally, and you may be familiar with this, but for others, you might be aghast at all the wires and all of the equipment that you actually have to somehow sleep with in a strange sleeping environment that is the sleep laboratory. And not only that, how much time and effort it takes to hook people up and to remove all the equipment at the end of the night. Look, we understand that we're not getting a typical night's sleep when we have people wear all of this equipment. And it's really interesting because sleep medicine is a fairly new field. It was only recognized by the American Board of Medical Specialties in 2007. And it was really a field that came about through research related to sleep, where polysomnography was developed, and then it came into the clinical realm. And some people state that sleep medicine is a guild focused around this polysomnography. And, there is an element of perhaps truth to that, in that we're so focused on this current testing environment and paradigm that I think it may have prevented us from advancing to perhaps more convenient, simpler ways of assessing the presence or absence of sleep disorders. And so we'll get into that a little bit more as we go through the talks. So one thing that I'd like to make clear up front, you may hear people talk about consumer sleep technologies in a more narrow term called wearables. Now, this is problematic for me because there are a number of technologies that don't touch you but are able to measure your sleep. And these are the contactless devices. And so the term wearable ignores the contactless opportunities that are out there. And ostensibly, being contactless is more beneficial because by not touching the individual, you're not altering or influencing the very thing that you're measuring. People typically don't like to wear things when they sleep. Before we had smart watches, how many of us wore a watch to sleep at night? So the reason I bring this up is I hope that we'll all use the term consumer sleep technology as we move forward and have these discussions, because it's a more broader, inclusive term for everything that's out there. And Dr. Dodrick touched on this a little bit, but I want to present some of this information from Global Market Insights about the sleep tech devices market that was about $12.5 billion in 2020 and is estimated to have a compound annual growth rate of about 17.5% in coming years, to be a market of about $40.6 billion by 2027. So this is an area of massive growth in the sleep health space. You can see when you look at the market share, it's broken down into non-wearables and wearables and hospitals, and they break it down by gender. Non-wearables also include beds and smart beds and things like that. Nonetheless, this is a huge market. We live in the time of the quantified self. And, honestly, this is a great thing for healthcare, because if you can measure it, you can manage it. And if you put the power of a sleep lab into the hand of the average individual, they can measure their sleep and ultimately, hopefully, improve their sleep in order to improve their health outcomes in general. So as these technologies have been coming along, the major physician-based membership organization focused on sleep, the American Academy of Sleep Medicine, began to realize that they needed to get involved because there was a lot of disruptive technology that was coming along, and they wanted to be a part of the conversation, and rightfully so. So about 4 years ago, they came out with this position statement related to consumer sleep technologies, which is really a kind of indicating their feelings about how it should be utilized in a clinical setting. And essentially they're saying that physicians need to have a general awareness of these technologies and a readiness to discuss them with their patients, and have a general notion of the framework of these devices, which I'll educate you about today. They also kind of equivocate in the sense that they say, well, most of them are not FDA approved, and talk a bit about them being black boxes and maybe lacking an understanding of how they work. But nevertheless, what we realize is that when patients engage with these technologies, what they're telling us is that they're in a pre-contemplative state of taking action to prioritize and improve their sleep. And when we live in a time where a third of Americans are not getting the 7 or more hours of sleep on a regular basis to support optimal health that's recommended by the CDC, when we live in a time where sleep medicine access is so limited, as Dr. Dodrick mentioned earlier, I think we have an opportunity here as patients bring this information to us. They're telling us, hey, I care about this. I want to make changes in my life in order to sleep better. And I think we need to, as providers, use that opening in order to help them improve their sleep and sleep habits. So these are the general concepts that are utilized by these technologies in general. So first you have accelerometry, and this is just essentially a way to measure movement. And for many decades, we used accelerometers, actigraphers in clinical sleep medicine and research as an indirect or proxy measure of sleep. Of course, sleep is measured by the electroencephalogram. It's the brain waves that tell us what sleep stages folks are in, but the actigrapher, by virtue of assessing movement, obviously when we're sleeping, unless we have sleep disorders, we're typically not moving. Some of those actigraphers also have light monitors on them. They have buttons you can press when you go to bed and when you wake up in order to help us understand a person's sleep. So a lot of these technologies use accelerometry. We also have respiratory frequency and amplitude. And what you have to realize about sleep is as we go to sleep, our temperature drops, our heart rate drops, our blood pressure drops, our respiratory rate and depth drop. And so these are things that these consumer sleep technologies are utilizing as ways to ascertain the presence or absence of sleep, and then also what sleep stage a person may be in during the night. And so some of these technologies, either through photoplethysmography or sonar or radar, are able to tell how much and how deep a person is breathing. Then you have heart rate variability, and pulse waveform and amplitude, which are in some ways proxy measures of our autonomic nervous system, the balance between the sympathetic and parasympathetic. And we know as we go into sleep and into non-REM sleep, we have more of a parasympathetic dominance. And then as we go into REM sleep, the sympathetic activity takes over. So heart rate goes down as we go into deeper stages of non-REM from N1 to N2 to N3. And then when we go into REM sleep, where we're dreaming, our heart rate can go up, our heart rate variability goes up. So a lot of these technologies are using that information in order to measure sleep. We have acoustic monitoring. Some are just assessing from a sleep apnea standpoint aspects of snoring, the sounds of snoring and breathing, in order to try to ascertain whether or not sleep apnea is present or not. Binaural beat technology I'll talk about a little bit later, but this is a way to introduce auditory tones to your ears. You basically provide a tone at a different frequency into each ear. The medial superior olive in your brain basically looks at the difference between those two tones, and they get an amplitude frequency that is that difference, which can then entrain your EEG. And we know that the EEG slows down as we go to sleep. So binaural beat technology is ostensibly a way to slow down an EEG and bring shepherd a person to sleep. I talked about the photoplethysmography, which is basically assessing the absorption of red and infrared wavelengths of light. by tissue in the finger or in your blood in order to, again, get a proxy measure of autonomic nervous system activity. And then lastly, some of these devices will also measure temperature. As I mentioned, we do cool off as we fall asleep. All right, so with that introduction, let's go into talk about some of these devices that are out there that either track or screen or diagnose sleep disorders. Of course, everybody's heard about the Fitbit. They're coming out with new models all the time. This is the Fitbit Surge and the Fitbit Charge H2. They use accelerometry and photoplethysmography in order to get heart rate and heart rate variability and movement as a way to measure sleep. You have the Oura Ring, which is kind of like a wedding band that can measure a lot of signals. So it gets heart rate and heart rate variability. It also can get body temperature, respiratory rate and breathing variance, and movement as well. And so a fairly sophisticated device that has a form factor that's attractive to many people. The Bedit sleep tracker uses something called ballistocardiography. This is placed underneath the mattress. When you lie in bed, as you deform it, it can detect heart rate variability, movement, and respiratory rate and depth in order to ascertain aspects of sleep. And you can see here from some of these figures, looking at the correlation, you can assess that the total sleep time is, you have the PSG on the bottom, and then you have the total sleep time for the Bedit sleep tracker. Here on the y-axis, the Bedit seems to overcall sleep a little bit relative to polysomnography. For sleep onset latency, it seems to be fairly accurate. It seems to undercall wake after sleep onset compared to polysomnography, and then perhaps overcall sleep efficiency a little bit. And sleep efficiency being the percentage of time that you're in bed trying to sleep that you're actually asleep. Then we have the Sleep Score Max and the S Plus device. The S Plus was the first version of this device, which is now the Sleep Score Max. This is a standalone device that you put at your bedside that emits radio frequency waves that reflect off you while you're sleeping and then are picked back up at the device. And as such, it's able to assess movement in bed as well as respiratory depth and rate. And then this has a sophisticated machine learning algorithms in order to detect the presence or onset of sleep as well as various sleep stages. And then we have the Sleep Score app, which is doesn't require a bedside device. This was the app that I was involved with the development here at the University of Washington. And we ultimately licensed this technology to ResMed, which sub-licensed it to Sleep Score Labs. But essentially what it does is it emits sound waves in the 18 to 20 kilohertz range that you can't hear. And they reflect off you while you're sleeping. It's kind of like a bat or a submarine. And then those sound waves are reflected back at the phone where they're picked up. And again, you can assess movement as well as respiratory rate and depth. And just showing you here, if you look up at the top, comparing wake versus sleep, you have the Sonar Sleep Score app. You have the radio frequencies, the Sleep Score Max compared to polysomnography, showing you here these instances where it's calling wake accurately and then inaccurately calling it sleep when it's actually wake, and over here when it's calling it wake when it's actually sleep. And you can see that we have this laid out for both light sleep versus non-light sleep, deep sleep versus non-deep sleep, and REM sleep versus non-REM sleep. I'll give you a table at the end which compares the accuracy of all these various devices, but you can see that here in particular has reasonable accuracy, but they're not perfect at this point, but they are continuing to get better as these entities collect more data. As their machine learning algorithms get more sophisticated, they're only going to get better at what they do. So if we look at these Bland-Altman plots for all of these products, I couldn't find one for the Fitbit Surge or the Bedit tracker, but what we have here is you can see the average total sleep time from polysomnography on the x-axis, and then you have the polysomnography minus the consumer sleep technology. So here for the sleep score, either S plus or max, the radio frequency devices, they tested this in people with obstructive sleep apnea, so we have to take this with a grain of salt. But you can see that at higher sleep durations, that there's a reasonable agreement here. As sleep durations go down, agreement becomes more problematic. If you look here at the sleep score app, drive is the sonar, that's the black dot. The S plus is the early version of the radio frequency is the open dot. Again, with PSG here on the x-axis, the difference on the y-axis, and again, good clustering here around 0, which indicates a good agreement. For the Fitbit Charge 2, disregard these square or these triangles, the red triangles. Those are in patients with periodic limb movement disorder. If we look at the circles, you can see again reasonable agreement. It would ultimately seem that again it's overcalling sleep a little bit compared to PSG. And then we have the Aura ring over here with this Bland-Altman plot, and you can just get a feeling. If you look at all of these together, you can get a feeling about how accurate they are, at least for sleep-wake detection compared to polysomnography. I do want to also mention the Amazon Halo, which measures motion, heart rate, and temperature, and then the Withings Scan Watch, which has motion, heart rate, and then also is able to measure pulse oximetry and respiratory rate. And they claim to be able to assess the presence or absence of obstructive sleep apnea, but I haven't seen any further data regarding the Withings Scan Watch in this area, but we'll just have to keep our eye on that technology as we move forward here. So this is the table that I put together for you that I kind of summarizes everything a little bit. I realize this is somewhat of a busy table, and we'll walk through this together, but just to give you a sense, because you're probably thinking, for my patients, which one of these devices is the best? Which one should I use? Which one should I recommend? And I think, the ultimate answer is going to be they all have strengths and weaknesses. So if you look at sleep, you can see that they're all reasonably accurate at detecting sleep. When you look at wake, which in many ways wake is the more challenging thing to ascertain, because you can be lying there motionless with your eyes closed and be totally awake. So it is a challenge. You can see that the S plus seems to do best there. The Sleep Score Sonar app also does reasonably well, as does the Fitbit Surge. If we look at light sleep, which we divide non-REM sleep into N1 and N2 and N3. N1 and N2 is light sleep. That's going to ultimately make up more than 50% of your night. Deep sleep is N3, and then you have REM. So light sleep, if we're looking at that, the Fitbit Charge 2 seems to do the best job there. And then let's talk about deep sleep here. You can see the Fitbit Surge, the S Plus and Max, and the Sleep Score also do pretty well from that perspective. And then lastly, if we look at REM, the two Fitbit devices and the Sleep Score Max and S Plus radio frequency device do a really good job there. So, when you're talking to your patients and which one is best, which one should I use, you also have to consider the form factor, comparing the contactless devices versus the wearable, and then is this a wearable ring? Is it a wearable watch? And then the bedded is somewhere in between, because it's kind of put under the mattress, so you're kind of contacting it, but not necessarily. All right, now we're going to move on to detecting sleep disorders, and I want to show you this video here, because when we originally developed the Sleep Score Sonar app, we really had a vision for this being utilized to tell whether or not somebody has obstructive sleep apnea. So I'll play this video for you. Sleep apnea is one of the most common diseases out there. It affects quality of life, it causes sleepiness and insomnia. It's associated with heart disease, stroke, diabetes, and increased mortality. It affects over 25 million Americans. And the thing about it is, most people that have it don't know that they have it. Apnea App is something that a person can use on their phone in their home sleeping environment, that can give them an indication as to whether or not they may be stopping breathing in their sleep. When we measure sleep now, we have people come into the sleep laboratory typically for one night. You come in, you're spending about 12 to 14 hours here. You get hooked up to a lot of different equipment. We put electrodes on patients' heads. We also measure breathing at the nose and the mouth. We measure their heart rate. We measure leg movements. And then we measure respiratory effort. You are kind of hooked up to a lot of equipment.
In a bedroom setting, you could think of a person who's just going to sleep. He can just turn on our app, press the record button, and then place the phone on his sideboard, just regular how he would leave it for charging, and then sleep. That's it. We are turning the phone into an active sonar. The concept is similar to as how a bat works. So we emit an inaudible signal using the phone speaker, and these signals would get reflected off the body and is recorded by the microphone. It actually monitors your abdominal breathing motion, and then it also detects all the other motions like leg movement, overall body movement, etc. When there are two people, they are actually at different distances from the phone. So our signal actually converts each of this distance into a unique frequency pattern in the phone. In order to test Apnea App, we actually worked at the UW Harborview Sleep Lab. So we actually placed the phone running our Apnea App on one corner of the bed. And then we compared the results which we obtained using our Apnea App and the original polysomnography test. We conducted this test for around 40 people and got an accuracy of about 98%.
Apnea App is still in the developmental stages at the moment, but we do believe that Apnea App has a lot of potential. We feel that a very simple way for people to indicate whether or not they have sleep apnea in their home sleeping environment has tremendous potential to help people live happier, healthier lives.
And who doesn't want that, right? So if we look at Apnea App a little more carefully here, we can look at the apnea-hypopnea index. So on a polysomnogram, the apnea-hypopnea index is basically the number of apneas and hypopneas that you have per hour. An apnea is a 10-second period of time where you have a 90% drop in airflow. A hypopnea is a 10-second period of time or longer where you have a 30% drop in airflow, and it's associated with either a 3% drop in oxygen saturation or an arousal on your EEG, which would be typically a speeding up of your EEG that would last at least 3 seconds. So here, if you look at the PSG on the x-axis compared to the AHI from Apnea App, we have a very high correlation. And if you look at the confusion matrix on the other side, where you look at the actual apnea level, again on the x-axis from PSG, compared to the detected apnea level from Apnea App, and we put this in bins, we typically consider no apnea to be an AHI of less than 5, mild apnea to be an AHI of 5 to 15, medium or moderate sleep apnea to be 15 to 30, and severe sleep apnea to be 30. You can see that we're accurately assessing this in 32 out of 37 individuals, and those that were inaccurately binned, there was just one that Apnea App thought had mild sleep apnea that had no apnea, and then there were 4 that Apnea App thought had no apnea that had mild apnea. So all of the issues of disagreement were right around that cutoff between no sleep apnea and mild sleep apnea. And mild sleep apnea, typically, we were only concerned about that in regards to sleep quality and daytime symptoms, excessive daytime sleepiness and things like that. We don't worry about cardiovascular consequences too much with mild sleep apnea. It's really the more moderate to severe sleep apnea that's a problem. So this is showing that there's promise here. If you look at the number of central events, so that's again a 10-second period of time or longer, where essentially the brain's not telling the body to breathe. So not only is there no airflow, there's no respiratory effort. A very high correlation between Apnea App and polysomnography. If you look at the hypopneas that I mentioned before, those are a little trickier. There's more gray area in there, and so the correlation isn't quite as high, but nonetheless remains high. And then for the obstructive events, also shows good correlation with polysomnography. So showing here, in the early stages of Apnea App, seem to have significant promise as a potential simple way to screen for sleep apnea in the home environment, if not ultimately at some point be used as a diagnostic test. Now, as I mentioned, we licensed the technology to ResMed. ResMed did further research on this. They're calling it Firefly. Here, this is a paper from a couple of years ago from Tyron and colleagues, where they looked at in their test set the sensitivity and specificity for various levels of sleep apnea, and here specifically looking at that moderate to severe sleep apnea. And you can see that a sensitivity of 88% and a specificity of 80% pretty good, and gives you an area under the curve of 0.92. So again, these technologies are pretty good right now, and they're only going to get better. Moving on to other technologies that are out there that potentially have the ability to diagnose sleep disorders such as obstructive sleep apnea. We have the Sonomat. This is a piece of foam that's covered in a polyvinyl chloride film, so that when that is depressed, it creates an electrical charge that is then assessed in order to take a look at respiratory rate and depth and presence of respirations, and a way to assess for sleep apnea related events. And you can see, if you look at the AHI compared to PSG, again, a high correlation. And then looking at the Bland-Altman plot on the other side, pretty good agreement at lower AHI levels. When you get to really high AHI levels, as far as the number of events, it gets a little less of agreement. But nonetheless, this has promise as well. And I know that what these individuals are doing are trying to look at this as a potential way to assess sleep apnea in kids, because as you might imagine, putting all that equipment on for polysomnography is difficult enough for adults, but if you try to do it in a child and have them keep it on at night, it can be even more challenging. I mentioned this acoustic monitoring earlier. This is snore sounds, where they're basically looking at aspects of snoring, the acoustic signatures, in order to try to assess the presence or absence of sleep apnea. For study 1, they had an apnea-hypopnea threshold of 10, so somewhere kind of between mild and moderate sleep apnea, and then study 2 was moderate to severe sleep apnea. And they had sensitivities in both studies between 89 and 93% and specificities of 92 to 93%. So showing, just the sound of snoring can be quite revealing. Now, of course, we have patients with sleep apnea that don't snore. If it was as simple as if you snored, you had sleep apnea, we wouldn't have to go through all this trouble. But nonetheless, showing that there are acoustic aspects of snoring that can be leveraged in order to assess the presence or absence of sleep disorder breathing events. Here we have the Withings Sleep Analyzer, which is very similar to the Bedit. So it's an air bladder under pressure. It's put under the mattress, but it also has an electronic component to assess for snoring. And so this can tell respiratory rate and depth, heart rate, and then presence in bed and moving around in bed. And I'm presenting this here because they're looking at it for OSA detection. And you can see that in panel A, if you look, the Withings is on the y-axis, the polysomnography is on the x-axis, and pretty good agreement whether your threshold for AHI is 15 or 30. In the middle, you have the Bland-Altman plot, which looks much like the others, showing at lower AHIs, better agreement. At higher AHIs, a little less of an agreement, where there may be some undercalling of events. And then the receiver operating characteristic curves at various AHI cutoffs, whether it's 5, 15, or 30, showing that the Withings performs pretty well for OSA detection too. So what about devices that treat sleep disorders? So Dr. Dodrick mentioned earlier the access problem, and we have a real access problem when we think about getting people the best standard of care for treating insomnia, which according to the American Academy of Sleep Medicine is cognitive behavioral therapy for insomnia, or CBT-I. And this usually occurs over 4 to 8 visits with a trained psychologist who would be board certified in this, or a board certified sleep medicine physician who would treat people's strategies for how to manage their insomnia complaints.
So it's not just going over sleep hygiene, but it's things like stimulus control. For instance, if you're in bed and you're not sleeping and it's been a while, get up and go to a different area of your dwelling. Don't turn lights on, do something that might make you drowsy, and then when you get sleepy again, go back to bed. You know, we recommend that because we don't want people associating their bedroom environment with not sleeping. So that would just be one of the many things that CBT-I would offer to people, and we know that it works as well, if not better, than medications long term. And so Pear Therapeutics has Somrist, which is a digital CBT-I. This is a way for people to get CBT-I without needing to interface with an actual individual, and may help tackle some of these access issue that we're talking about here. ErgoNight is an interesting product. They call it a teleneurofeedback. Essentially what you do is you wear this device during the day 3 times a week for about 15 to 20 minutes. It's measuring your EEG or your electroencephalogram, and then it's giving you, it trains you, or it's giving you exercises in order to relax you, to slow your EEG down, and then when you're successful, it lets you know that it's happening. And so it's kind of training your body and your brain to slow down, which is what it needs to do in order to fall asleep. And so this makes sense. We know that the EEG does slow as we go to sleep. And so ErgoNight is something that could be considered as a consumer sleep technology in people that have insomnia. Maybe they've already done CBT-I or didn't want to do it. And this is a product that they could consider. To Breathe, or what's called device-guided breathing, is another product that can be utilized. And this is similar to ErgoNight in the sense that people wear this during the day, and what they do is they train themselves to breathe in concert with different tones. And the tones slow the respiratory rate down, and that's something that of course happens as we fall asleep. This helps reduce neural sympathetic activity. And it's interesting because this was originally developed as a treatment for hypertension. It's called Respirate. And when they were testing it for hypertension, they found that a large percentage of individuals that were using it were actually falling asleep while they were using it. And so now it's being used as a treatment for insomnia. So this device-guided breathing, again, would be a way for an individual to train themselves through breathing exercises to slow their respiratory rate, mostly by extending their exhalation in order to help them fall asleep. Talked about binaural beats at the very beginning of the talk. The tones of 2 different frequencies in each ear. Superior medial olive, here's the difference between the two, and has a frequency amplitude that is that difference that can then entrain the EEG. And then this device here is the Sleep Shepherd, is measuring the EEG in real time, providing the tones in real time to help slow down the EEG to hasten sleep onset. So it's another product that's out there that has some validation behind it that people can look at. Now, of course, you know, again, people generally speaking don't like to wear things like this on their head when they're sleeping, so it has a form factor that could potentially be problematic, but there's research there showing that it can be effective. Of course, if we have this talk, we have to talk about smart beds, and I think, you know, the Sleep Number 360, of course, has the ability to adjust the firmness. If your bed partner is snoring, you can raise the head of the bed, which provides a mechanical advantage to help open the airway. It has the ability to warm your feet when you're going to sleep, and then also measure your sleep at night in order to give you an assessment of the quality of your sleep. I think this is just the beginning of smart beds. Smart beds are going to become more and more intelligent as we gather more data and hopefully be able to have the bed make alterations in real time in order to optimize an individual's sleep. And so we'll have to keep our eye on this space, but this is the first iteration of that. You have the Philips Smart Sleep, which uses what's called auditory closed loop stimulation, ostensibly to boost deep non-REM sleep, or N3 sleep, which
we feel is probably the most important sleep stage. It's a sleep stage that you get back first if you've sleep deprived yourself. And they're basically saying, look, you're too busy to sleep the full 8 hours or, whatever your body needs, which is, 7 or more hours is our general recommendation. So why don't we boost the amount of N3 or deep non-REM sleep that you have? So what it does is this auditory closed loop stimulation it's measuring your EEG, and then it introduces clicks at this perfect point when delta waves, these slow waves are happening. And what it can do is increase the amplitude and the number of slow waves that occur. So it's kind of, juicing up your slow wave sleep, so to speak. I think they have some work to do to continue to prove their claims, and there's a form factor issue potentially here as well. But nonetheless, an interesting notion. N3 sleep, again, important to memory, growth hormones secreted, really important sleep stage. So trying to increase the value of that seems to be a good idea. So went through a lot of products here. Some have more validation than others. Some are thinking about getting FDA approval. Some are not. So I just want to make sure as I go through this, people realize, we are a little bit on thin ice as scientists here as we look at all of these consumer sleep technologies. This is the early stages and the early phases of these things. I think, certainly they have a level of accuracy that's good enough to be used and to be helpful for you and your patients, but it's going to get better over time. So I want to pivot now to the challenges and issues around these technologies. So one is related to my comment I just made is few validation studies do exist. And so, this may be premeditated by developers who are saying, we're not trying to get FDA approval. We're not creating a medical grade device. So why would we go through that? Because then there's a chance that we could debunk claims that we're making. So that might be the most cynical view of why that would occur. Another view would be that, a lot of money has been invested in getting these technologies to this point, and so some of this is proprietary, and as a result, they're holding it close to the vest, and they don't want to share it for it to get validated independently. And I think those are all reasonable considerations. But we do, as we think about these technologies, we have to definitely acknowledge that they are doing something. They're measuring aspects of sleep that we're not currently measuring in the sleep lab. And they're going to get better and better at that as they go forward. And so this really is kind of like a new tool to understand human sleep. And I think it is advancing the field by virtue of that. The FDA has their eye on this. This is their most recent guidance document from September of 2019, and basically letting these device manufacturers know how they're going to approach these things. And essentially, they're really only looking at mobile apps that they consider to be medical devices, where if it malfunctioned, it would cause a risk to a patient safety. So if we think about what that might be, software functions that are not medical devices would be something that say would track a normal baby's sleeping and feeding habits, or help healthy people track the quantity and quality of their normal sleep patterns. So basically what a lot of these consumer sleep technologies are currently doing. Things that are considered medical devices would be software functions that are using a sensor or something within the mobile platform itself, so accelerometer, microphone, things like that would measure physiological parameters such as the EEG or limb movements or body movements in general during sleep, and are intended for use in the diagnosis of specific diseases or conditions such as sleep apnea. So you can see, I think the key word there is diagnosis. They don't talk about screening, and so I think the first step is going to be for these products to be used for screening for these sleep disorders, but certainly when you get to a point where we're talking about diagnosis, then the FDA is going to be involved. Another important issue to think about is highlighted here.
This is related to personal privacy. So the Jawbone Up was a consumer sleep technology that was out 5 or 6 years ago. It's not around anymore, but nonetheless, they had a lot of users at the time. And back in 2014, there was a reasonable sized earthquake in the Napa, Sonoma region of California. It was, I think it was a magnitude 6. And what Jawbone Up did was they assessed whether or not people were asleep or awake at the time of the earthquake, and then whether or not they went back to bed. And you can see here that the closer you were to the epicenter of the earthquake, the more likely you were to wake up and the less likely you were to go back to sleep. So millions of hours of sleep were lost as a result of this earthquake. Now, this is really cool, but it also makes you wonder if people that bought Jawbone Up agreed to participate in this type of research, essentially. And so it makes you go further to think, well, what are the social consequences about the information these technologies are collecting? Is there courtroom admissibility? What about unintentional sharing or tampering with sensitive data during sleep or in the bedroom? And I think that discussion needs to occur and be ongoing as we figure out the role of these sleep technologies going forward. Another real issue, and I think we all experience this as providers, is the fragmented nature of the mobile health world. We have electronic medical records, which in some sense improves our practice and facilitates our practice. In some sense, they also make it more challenging and difficult. But right now, when patients bring consumer sleep technology data to us, they, it's not in the medical record. It's not integrated in a way that we can access it easily, and we kind of find ourselves having to flip through the individual's phone in order to get the information. And so hopefully, as these ambulatory technologies, not just consumer sleep technologies, but smart weight scales or blood pressure monitors or glucose monitors, these things will be integrated into our current healthcare electronic medical record platform in a way that it makes our jobs easier and not more challenging. And I want to finish this part of my talk with this right here. So, the way that we measured sleep before consumer sleep technologies was much like as if we were looking for our lost car keys on this street. Let's assume we don't have a flashlight. You're only going to find the keys under the flashlight. Well, right now with polysomnography, we're only measuring sleep for one night in a strange environment hooked up to all of this equipment. We know it's not representative of a typical night's sleep. Well, what consumer sleep technologies are doing is they're opening the door, essentially. It's an ecologically valid measurement of sleep. And what I mean by that is it measures it in your typical sleep environment, not in the artificial bedroom of the sleep lab. And it can do it longitudinally, night after night, week after week, month after month, year after year. And we know that there's substantial night-to-night variability in sleep. And so being able to get a more comprehensive picture of someone's sleep, I think, is going to make us more accurate at assessing sleep disorders and improving sleep going forward. So what have consumer sleep technologies taught us about sleep? So I'm going to go through and show you some data from some of the devices that I've already showed you the validation and accuracy information on, including the Fitbit Charge, the Oura Ring, the Withings Sleep Analyzer, the Sleep Score app. This is the sonar, does not require a standalone device at the side of the bed, and then the Sleep Score Max and the S Plus, which are the radio frequency devices. So first study, and I think these are kind of exciting opportunities to understand, to look at massive data sets regarding sleep around the world, okay? So this was a Fitbit Charge HR study, looked at sleep data from over 500,000 nights from over 23,000 users for 1 month back in 2017, pre-COVID. Age was binned into 5 years, categorical bins. They were only looking at major sleep periods. The bed and wake times were determined automatically by an algorithm in the Fitbit. And then the analyses were done using SPSS 25 and a three-way factorial ANOVAs and between subjects factors, country, age group, and sex were run separately for each independent variable, which included sleep duration, bedtimes, and wake times. So if we look here, let's look at the weekday at the top first. So we have it divided here into Australia and New Zealand, which together are considered Oceania. And then you have Singapore, Hong Kong, and South Korea, which together would be considered East Asia. And if we look at, we have these 5-year bins in age at the x-axis, we have weekday sleep durations on the y-axis. And what you can appreciate is that the folks in East Asia are not getting the 7 or more hours of sleep recommended to support optimal health in adults, regardless of how old they are. And the folks in Oceania are doing a bit better. What you can also appreciate is the U-shaped nature of the curve, which shows, as we age, our sleep duration goes down and perhaps hits a nadir in our late 40s to early 50s, and then increases a little bit as we get older. And this might just represent in our mid 40s and early 50s, we have children we're raising, we have parents who are aging we're taking care of. We may be in our busiest points in our career, which we know are all things that erode sleep opportunity. If you consider why East Asia is not sleeping as much, it's mostly due to later bedtimes compared to wake times. So this is an example of a consumer sleep technology providing massive population level data that could be used to investigate or develop a public policy initiative to understand why are bedtimes so late in East Asia, and could we go forward with a public policy initiative to try to change that. Now, if we look at weekends here, you can see it's still the same thing, that East Asia is sleeping less than Oceania, but it seems to be more linear here, which may just be representative of this notion that people may sleep less as they get older. But nonetheless, there's still a difference there, and it's still mostly related to a later bedtime amongst the East Asian populations. We also look a lot at this notion of a difference in sleep duration between weekdays and weekends. We know that when bedtimes and wake times are different on weekdays and weekends, that's usually a surrogate measure of poor sleep health. And so this slide right here is just showing you the difference between weekday and weekend sleep. And it's showing you in the younger populations are sleeping longer on weekends than during weekdays. And then as we age, it becomes a little more consistent between weekends and weekdays. This also shows that this is a bigger problem for females than for males. So if we're thinking about ways to improve the problems with shorter sleep in East Asian groups, we may want to focus those efforts on females. Okay, so let's move along here. What about this? Can consumer sleep technologies differentiate those with insomnia from healthy sleepers? So this was a study I was involved with, a group at Washington State University in Spokane, looked at 44 individuals with an International Classification of Sleep Disorder Volume 3 criteria for chronic insomnia compared to 29 healthy sleeper controls. We used the sleep score max for 8 weeks and looked at sleep measurements analyzed for both means and within subject standard deviations. And so the results are shown here, and I'm going to point out the differences in the means. And so here, if we look at wake after sleep onset, was higher in the insomnia group than in healthy sleepers, as we would expect. Also, mean total wake time was higher in the insomnia group than in healthy sleepers, and sleep efficiency was worse in those with insomnia than healthy sleepers. So these would all be things differences we would expect to see in people that suffer from insomnia. Now, sleep latency, or how long it takes you to fall asleep, was a bit higher in the insomnia group than the healthy group, but this was not statistically significantly different. And then if you look at the various sleep stages, deep, light sleep, REM sleep, time in bed, total sleep time, no differences were seen there. Then if we look at within subject standard deviations, this is the night-to-night variability in these measures. And once again, you can see that the insomnia group had more variability in wake after sleep onset or total time awake. and then more variability in sleep efficiency, as well as more variability in how long it took them to fall asleep. So this is, again, this is what we would expect. We know that healthy sleep is typically consistent sleep. Bedtimes, wake times are consistent, sleep durations are consistent on weekdays and weekends, and that when variability comes into the mix, can either be a cause of problems or it can be a result of problems. And that's what we're seeing here. So this is a proof of concept that these technologies, some early research showing that these technologies could be used to help objectively ascertain whether or not somebody that you're seeing in clinic who's telling you that they have insomnia has it when you look at it objectively. This was the Withings Sleep Analyzer study that I alluded to earlier. This is, I think, a really interesting study that just came out, and looking at over 67,000 individuals who used the Withings Sleep Analyzer for at least 170 nights. And they were assessing the presence or absence of an AHI of 15 or greater. Apnea Hypopnea Index, 15 or greater, again, is moderate to severe sleep apnea. And what they found was they found a global prevalence of OSA of 22.6%, which, when you consider the general population, that's a much higher prevalence estimate than we typically report from a lot of the landmark epidemiologic studies that we refer to in sleep medicine. And OSA was misdiagnosed 20% of the time based on a single night of measurement. And this really jumps off the page to me and gets back to what I was saying earlier about this notion of the longitudinal nature of these consumer technologies provides such a greater opportunity to understand the totality of somebody's sleep that we know will vary from night to night. And we also know sleep apnea is going to vary from night to night, depending on what body position you're in. Did you drink alcohol before you went to bed? Were you sleep deprived before you went to bed? And so on and so forth. So here, if you look at the receiver operating characteristic curve, you can see that they get the highest sensitivity and specificity out of about 14 nights of monitoring. So this is disruptive. This is potentially transformative in my mind, where we may be able to become more accurate at assessing sleep apnea by doing it longitudinally using these technologies. We talked about digital CBT-I earlier, the SOMRIST. Well, does that work? And I think one of the opportunities these technologies may afford us going forward is the ability to objectively measure the benefit of our interventions to improve health. So this is a small study. It looked at 11 individuals that went through that were measured by the S+, and 7 of them went through the SHUT-I digital CBT-I program. SHUT-I is actually an early version of SOMRIST. So it was 5 men and 2 women. It was a non-counterbalanced pre-post comparison baseline study. And so there wasn't really a placebo group, so we have to take all of this with a grain of salt. But nonetheless, the device did show that those that, when they were getting the CBT-I, they slept 6 minutes, they fell asleep 6 minutes faster, they woke up fewer times, they had 13 fewer minutes awake at night, they had more deep non-REM sleep, spent less time in bed, and had a higher sleep efficiency. And then from a subjective standpoint, there's a device called the Insomnia Severity Index, which can measure aspects of insomnia, and there were substantial improvements there. So this is a proof of concept showing that this device can show that the intervention, the CBT-I, did improve aspects of sleep. All right, now I'm going to walk us through some things that are more consumery here. And again, this isn't hardcore research, but I think this is the first foray that the field has really taken into trying to prove the claims of various products that state that they improve sleep. And so this is a question that maybe we've all thought: do air purifiers improve sleep? So using the Sleep Score Max device, looked at 36 adults. This was an 8-week-long field study. It was a pre-post intervention design implemented, which compared 4 weeks of nightly product use to 4 weeks without the product. and then an Allen Breathe Smart air purifier was in the room 24 hours a day. So first of all, if you look at these subjective measures, you can see all the subjective measures improved. So time to fall asleep, number of times woke up during the night, and time awake after falling asleep onset. After falling asleep, all were reduced. And then ability to sleep through the night, feeling well rested in the morning, and better sleep quality, and number of nights you felt satisfied with your sleep were all increased with the use of the air purifier. And there was a small but significant improvement in observed and objective sleep quality when using the air purifier. And if we look here, you can see with the air purifier, again, small but significant improvements in the number of awakenings, wake after sleep onset, sleep efficiency, and sleep maintenance. All those things got better, and percent wake after sleep onset went down. So, is it a perfect study design? No, and perhaps they'll get better going forward, but based on this result, you can say that air purifiers do appear to improve sleep. How about sound machines that people use? This is a quite common thing for people to have in their bedroom. This looked at 30 individuals, 63% male, were measuring their sleep with the radio frequency S+ device, and they filled out questionnaires before and after sound machine use. Again, this was a within subjects pre-post intervention design with a 2-week baseline period and 2 weeks of sound machine use. And then a multi-level regression impaired t-test were used for statistical significance. And this is an interesting finding here for me. When you look at, what are the reasons for using a sound machine? I would have thought most people would say, I use it to drown out spikes in noise in my environment, whether it's my neighbors or pets or sirens in the street. But in fact, most people were saying it helps them relax and unwind and keep their thoughts, keep away thoughts that distract from sleep. So those are the number one and two reasons why people were using these devices. If we look at the subjective measures, again, they all got better. Time to fall asleep improved. Ability to sleep through the night improved. Sleep quality improved. Feeling rested in the morning improved. And at baseline, 60% of participants reported having racing thoughts or worry when trying to fall asleep, and this was reduced to only 30% when they were using the sound machine. So there's subjective improvements here. Unfortunately, there were no objective improvements that were observed here. So I think, and that's consistent with some other literature that's out there. So it would seem to suggest subjective yes, objective no, or maybe the jury's out. We need to do more research in this area. How about weighted blankets? This is a kind of a trendy thing for people to think about in regards to their sleep. This study, and a weighted blanket is going to be a blanket that weighs about 10% of your body weight. So this was a 6-week field study, non-counterbalanced pre-post design. The ResMed S+ device was used and included 14 women and 16 men. And again, for the subjective measures, they got better, perhaps not surprisingly, but feeling more relaxed, feeling more well-rested, better sleep quality, and then falling asleep quicker and having less bedtime stress. All revealed themselves. But then objective measures as well. Once again, modest but significant improvements in wake after sleep onset, so a reduction there, improved sleep efficiency, improved sleep maintenance, increased light sleep, and less percent wake after sleep onset. So this would suggest that weighted blankets do improve sleep objectively and subjectively. How about olfaction? This is a developing area where, are there fragrances that could help us fall asleep? This study looked at 31 females, and this actually did have a placebo group, a placebo pillow mist. So the design was 2 weeks of product use, a washout week, and then 2 weeks of placebo use, and then a washout week. And the radio frequency devices were used to assess this. And for the self-report sleep outcomes, onset of sleep was less, took less time to fall asleep, fewer awakenings, and less wake after sleep onset. The objective outcomes for the sample as a whole did not show a difference. And the sample was actually individuals that had a little bit of sleep disturbance or sleep problems. When they did a sensitivity analysis looking at people with fewer sleep disturbances at baseline, they did see improvements in sleep efficiency and sleep maintenance. So this suggests that perhaps certain fragrances may improve sleep in people that already have reasonably healthy sleep, but may not be able to improve sleep in those with sleep disturbance. Now let's move into thinking about sleep during COVID. And there's a lot of research that's looked into this. You know, generally speaking, it's hard to make monolithic statements about sleep during COVID because obviously if you had the disease, if you were worried about getting the disease, if a family member had it, if your employment was affected by it, you could see that that would have negative impacts on sleep. However, if you all of a sudden were able to work from home or remotely, that could have positive influences on sleep. And so how does this balance out? Well, let's look at some of these studies here. The first one looks, this is an Oura Ring study, over 113,000 users in 20 countries from January through July of 2020 compared to the same time frame in 2019. And they looked at sleep midpoint, which is a proxy for chronotype, and then mid-sleep variability. And again, variability in sleep is essentially less healthy. You want more. Consistency is better. And so this was a meta-analysis. And what you can see here is mid-sleep, and I focus in on North America down here. As you go more towards red and yellow, COVID was more prevalent. But mid-sleep got delayed a bit during COVID compared to pre-COVID. And this would seem to suggest that it might be that people during their regular work schedules were forced to have to go to bed earlier and wake up earlier than their body wanted to. And with COVID and with the flexibility and schedule that COVID gave them, they could go to bed a little bit later and wake up a bit later, and it shifted that midpoint later, and that maybe they're sleeping more consistent with their circadian needs. You look at the mid-sleep variability did also reduce during COVID. So it was mid-sleep was delayed, but then it was also more consistent, which suggests that sleep was healthier, at least in the individuals that were wearing the Oura Ring during COVID. How about COVID-19 suppression measures and the impact that had on population sleep? So this used the Sleep Score app, the Sonar app, over 177,000 nights from over 7,000 users, nearly half female. This was all in the United States. And the period of COVID was considered to be defined as beginning on March 16, 2020, because that's when there was increased awareness of the disease, and there was a sudden increase in internet search activity in Google right around that time. And it's also when a lot of lockdowns began to become implemented. So here we have on the x-axis 2-week intervals. On the y-axis we have sleep duration. And what you can see here, if we look at this red dotted line, which is the COVID-19 search interest, that as COVID-19 search interest goes up, lockdowns began to get implemented, and sleep duration, in fact, increased. So you might consider 7 minutes to be modest, but when you're talking about the population as a whole, this is a massive impact. People, at least those that were using the Sleep Score app, were sleeping substantially more during COVID than before. And then what about the impact on weekday and weekend sleep patterns in the USA? This looks at the same data set and the same measure of the onset of COVID as what I just mentioned previously. And here, if I can just simplify this slide for you, in pre-COVID, we were sleeping, or the population was sleeping about 10 minutes longer on weekends than weekdays. Again, longer sleep on weekends than weekdays indicates you're trying to catch up on sleep. It indicates you're probably sleep depriving yourself during the week. During COVID, this was reduced to 3.8 minutes longer on weekends compared to weekdays. So the difference between weekday and weekend sleep duration is 2.5 times greater before the pandemic than during it. So again, suggesting that the pandemic was good in the sense that it offered more opportunities to sleep for people that were had more control over their schedules, and as a result, there was more consistency in weekday and weekend sleep times. And this got me thinking about this study from a number of years ago called the American Time Use Survey, where the researchers assessed the way individuals spent every minute of their day over, I believe, about a 2-week period of time. And of course, work correlated most strongly with sleep time, but travel was also a big factor that correlated really strongly with sleep time. And so I think, not surprisingly, that people could work from home, their commutes were taken away, and at least a portion of that time was repurposed to increasing sleep duration and increasing sleep health. And then what about sleep schedule changes during the pandemic related to your circadian preference? And we're talking about, are you a night owl? Are you a morning lark? That type of thing. So we compared bedtimes and wake times during the 4 weeks before and after the California shelter-in-place order in March 19th of 2020, and then looked at differences in average bedtime and average wake time compared to 5 self-reported circadian preferences along that continuum of morning lark to night owl. So this looked at nearly 1,500 subjects, nearly 70,000 nights. And what you can appreciate here, so on the x-axis, we have going from strong morning to strong evening circadian preference. This is when you feel like you're at your best, like your feeling best rhythm is essentially. The majority of people are actually neither, but there is this continuum here. And if you look, median bedtime during the lockdown compared to before got delayed a little bit. And if you look at median wake time, again with the same x-axis, that also got delayed. But what you can begin to appreciate is that it was more delayed in those with an evening preference than those with a morning preference. And that is shown here. So we have change in minutes going from strong morning to strong evening. And the mean is in the middle. And what you can see is that in general, wake-up delays were greater than bedtime delays. And the magnitude of the delay increased with evening preference. And so evening preference more strongly associated with wake-up delay than bedtime delay, and it was associated with greater bedtime delay. And this makes sense because evening type people can struggle in today's society that has an expectation for them to wake up at an hour in the morning, where their chronotype, their preference would be such that they would not want to wake up at that time. And so COVID gave them the opportunity to sleep on a more ad hoc schedule, and we can see that ended up being perhaps more beneficial for those with evening types than morning types. All right, let's move on to this topic here, talking a bit more specifically about the EEG. And this is getting, we're still in the consumer sleep technology realm, but this is a little more forward thinking. So waveforms provide trillions of data points, the EEG, and right now we measure the macro structure of EEG by scoring it in 30-second epochs to determine sleep stages in order to come up with percentages of sleep through the night for any given individual. Well, the growth in artificial intelligence and machine learning algorithms is beginning to show us that if we look at the sleep microstructure, there's something there that we haven't been seeing. And so this is like this picture here. This looks like a temperate rainforest, maybe on the Olympic Peninsula near where I live out here in Seattle at first blush. But if you look more carefully, what do you see? You can see a panther here. You can see a jaguar over here. Here's an orangutan. There's a tree sloth up here. And this is an elephant to the side. And so I think, for decades or longer, we've been looking at the EEG and having it hand scored by sleep technologists who do a great job, but there's substantial inner score reliability, and there are trends and aspects of the microarchitecture of sleep that the human eye is just not going to be able to understand or pick up. And what we're beginning to learn from that is that actually, if you look at that microarchitecture of the EEG, you can develop something called the brain age, which is essentially comparing a metric of brain age to your chronological age. And what we're learning is that your chronological age does not necessarily define the age of your brain. And so I've done some work with Enso Data, which is a sleep-focused AI company in Madison, Wisconsin, and other researchers have looked at this as well. We know that diseases like Alzheimer's and traumatic brain injury and schizophrenia, from an MRI perspective, can increase brain age. But MRI is costly and onerous, and so the EEG is ostensibly easier to obtain. And so researchers, include ourselves, including the group at Massachusetts General Hospital, have looked into this. And what I have here is basically the bottom line. So each one of these figures is an individual, and the CA is their chronological age and the BA is their brain age. And so if you go along the diagonal here, these are individuals whose chronological age is equivalent to their brain age. Now at the top, this is called a sleep hypnogram, which is just showing you the way that sleep architecture unfolds during the course of the night as we go through wake, REM, N1, N2, N3 sleep. Then this is a spectrogram looking at the various frequencies. And so you can see those with healthier brain ages have these really robust sleep spindle spectrograms. This is about 14 hertz. Sleep spindles occur in N2 sleep. And they also have robust delta sleep signatures down here. If we compare that to those whose brain age is substantially older than their chronological age, over here you can see that these sleep spindle spectrogram signatures are much lighter, and so is the delta wave signatures at the bottom. So I'm envisioning a future where we have brain age as a new vital sign when we see patients, and hopefully if they make changes in their lifestyle, stop smoking, get their diabetes under control, start to exercise, and so on and so forth, that maybe there's an opportunity to reverse this rapidly aging brain. So you can see, as far as the covariates at the top, the things with an inverse relationship are things that we would expect. N3, probably the most important sleep stage. If N3s goes up, brain age gets better. If N3 percentage goes up, brain age gets better. If your sleep efficiency goes up and your total sleep time and your N2 sleep time improve, all those things are going to improve or be associated with improved brain age. On the other side, if your respiratory disturbance index, which is basically a measure of sleep apnea, goes up, your brain age goes up. If your N1 percentage, which is light sleep, which should only be a shorter percentage of the night, maybe 5 to 10%, if that goes up, your brain age goes up. If wake after sleep onset time goes up, your brain age goes up. So I think, as we think about the EEG, it's interesting in sleep medicine, we've been going through diagnostic reductionism, where we're moving away from the PSG to these home sleep apnea tests that don't measure the EEG anymore. But this data is suggesting that it might be that the EEG is the single most important component of a sleep study. And so if you take this a step further and you tease out, if you look at the brain age index, which is the brain age minus the chronological age, and you look at individuals with significant neurological or psychiatric disease in panel A, and you compare that to others without those diseases, you can see that there is a increased brain age index in those that are psychologically diseased. And also, if you look at hypertension and diabetes compared to not having hypertension and diabetes, there is also a brain age consequence to having those diseases. So it's kind of proving that things that we think would untowardly impact the health of the brain, in fact, make this brain age a little bit worse. So I bring this up because, and then lastly, other things that we look at too, beyond cardiovascular disease and psychiatric disease, but like BMI and memory difficulties and gender. Male gender actually is associated with the worst brain age. Being sleepy, or ESS greater than 16, that's the Epworth Sleepiness Scale, or being obese. Those things are also associated with an older brain age. So I bring that up because there's a product out there called Irritable that's just come out that can measure the EEG. It measures the electroencephalogram, the electrooculogram, and the EMG, and the photoplethysmography. And so this is kind of getting EEG in an ambulatory way, and I can't help but think that if we marry this with some of these machine learning algorithms that can assess brain age, that we might really be onto something for our patients. All right, and as we go through here, and I got a few more slides and then we'll have more questions, but I wanted to finish on this. So does good sleep produce more happiness? And we think it probably does, but we have never really looked at that. So this used the Sleep Score Sonar app, looked at over 1.2 million nights and over 72,000 users across 26 countries. This was back in 2019. We only looked at countries where there were over 1,000 subjects. And the happiness index data was taken from the World Happiness Report, which is an index calculated based on an individual's own assessment of their well-being in a nationally representative survey. So I'm just curious, sometimes I like for people to pause and think in their mind, what country do they think is sleeping the most and the happiest? And so maybe get an idea. Dr. Dodrick, you might have it. What are your thoughts about that?
Which country is happiest?
Yeah.
Okay, I'm going to take a guess at Denmark.
All right. Does anybody else have any other guesses? Happiest, sleeping the most? All right, I'll move on here. So Finland is Finland. So if you look here,
Close.
that is close. You're on the right geographical region. So there was a significant positive relationship between happiness index and total sleep time, such that a 1-point increase in happiness score was associated with an extra 8.16 minutes of sleep, and a 1-point increase in happiness score is associated with an extra 9.48 minutes time in bed. So you can see New Zealand and Finland looking really happy and sleeping plenty. You can see that India sleeping much less and less happy. You can see that South Africa and Russia maybe sleeping more than their happiness would indicate. United States is perhaps a little happier for the total amount of time that they sleep, and Canada is tracking right along the line there. But yeah, there was a significant correlation there, and really nice to see, because we know that sleep deprivation is associated with irritability and lack of patience and things like that can affect happiness and relationships. So, as I wrap this up, I think about what are the opportunities for consumer sleep technologies. So we talked about objectifying interventions, objectifying benefits from interventions. So this could be used in pharmaceutical trials, for instance, or ecologically valid therapeutic efficacy assessments. So let's say you have a patient with insomnia, you prescribe them Somrist. You could assess whether or not their sleep's getting better, or if you prescribe them a pharmaceutical drug, you could assess whether their sleep's getting better with one of these devices. Transportation safety related assessments are also possible as far as commercial motor vehicle drivers and their fitness to drive. I talked a little bit about some of these, weighted blankets and sound machines and air purifiers, but there's all kinds of product validation that can happen to assess these products that people are making, and they make claims about improving sleep. Are they actually improving sleep? Getting longitudinal assessments of the natural history of various diseases, like for instance, narcolepsy, a central nervous system hypersomnia. We know it causes people to go into REM sleep really early in their sleep stage. And the question is, we don't know how frequently that occurs night to night. And so this gives us an opportunity to understand the natural history of that disease better. Ambulatory clinical threshold assessments for preventive medicine. And I think this is kind of the patient of yours who brings their consumer sleep technology data to you and says, gosh, I'm getting bad scores and it's giving me advice, I'm making changes, but none of it's getting better. And that might be the patient to dig in a little deeper, ask some questions about snoring, sleep duration, and things of that nature, and make a referral to a sleep provider. And then lastly, leveraging what's called the Hawthorne effect, which we know that when in clinical trials, when you observe somebody, sometimes the very thing you're measuring will get better. So for instance, if you're in a clinical trial related to a treatment for obesity, even the group that gets placebo, oftentimes they lose weight because all of a sudden people are paying a lot more attention to their obesity. The patient themselves is paying more attention to it, and they may change their lifestyle in a way to make it better. And so people, by virtue of measuring their sleep or having their sleep being monitored, may ultimately want to please themselves by getting numbers that look better. And that'll bring me to my last couple of points here, which is there are some people in sleep medicine that are putting forth the notion of orthosomnia, where they're saying the exact opposite, that if we're measuring sleep more with the quantified self with these technologies in the home, it's putting undue pressure on people to sleep better, and as a result, that pressure is creating anxiety, which is causing people to sleep worse. But what we know is that there's only a small case series out there that suggests that this is the case. So there's four patients that are described in the medical literature to suggest that this is what's happening. And as I think about this and the Hawthorne effect, I can't help but think about Jeremy Bentham, who is a 19th century English philosopher, and Michel Foucault, who was a 19th and 20th century French philosopher. And they developed this notion of panopticism, or the panopticon. And Jeremy Bentham actually had this prison design where it was circular. All of the prisoners could see the guard tower in the center, but they couldn't tell whether or not they were being observed. But the guard tower could watch all the prisoners all the time. So the prisoners had to assume that they were being constantly observed. And when you think about it, we're all being constantly observed now between, what we put into Google, and there's cameras everywhere, and how we use our phones. And so I think that this notion, for me anyway, that people voluntarily using consumer sleep technology as a part of the quantified self is a sort of self-imposed panopticism, but with a positive outcome, because panopticism can be normalizing. It can create normalizing behavior, okay? And so people may begin to think more about their bedtimes and wake times on weekdays and weekends and how long they're sleeping and things like that. So I think that this is probably going to shake out as being certainly more positive for sleep than this negative notion of orthosomnia. And so, these key takeaways for you all in your practices, and maybe to try to sum everything up here is, look, consumer sleep technologies, they're accurate, they're getting better by the day. Feel free to use them in your practice, and when patients bring that information to you, I think you can believe that they are providing a reasonable estimate of their sleep. And a day is coming where they'll be eventually used to screen and potentially diagnose sleep disorders. And of course, a lot needs to change about the paradigm of the current sleep care and the way that we diagnose and treat sleep disorders for that to occur, but I think that day is coming. And the ecological validity and longitudinal nature of these technologies allow us to understand human sleep in ways that we've never been able to do before, and so that's really powerful and exciting. And then these devices can be used now to assess the impact of sleep interventions, whether they're by prescription or over the counter. So if you have a patient that has one of these devices and you have an intervention, feel free to look at their results when they bring it back in order to assess whether or not you're successful in your treatment. And with that, I will stop again, and I'm happy to take your questions. Thank you so much for your attention.
Thanks, Dr. Watson. Well, I'm sure your prescription for all of us is to have a good night's sleep and be happy. So we'll do that. But listen, thank you very much for taking 2 hours today to spend time with us, and for giving us really just a fantastic overview of consumer sleep technologies. And we hope to be able to entice you back here to give us an update, because obviously this is exploding in emerging technology, and we're learning a lot rapidly. So we hope to be able to get you back to talk to us. So thanks again.